Hello, everyone. I'm Manu Agarwal, fellow physician in the Division of Cardiovascular Medicine at University of California, Los Angeles, and I'm delighted to share our original investigation paper titled Cardiovascular Disease and Hospitalizations with the Diagnosis of Coronavirus from Pre-COVID-19 Era in the United States, a national analysis from 2016 to 2017, which was published online in September and in a subsequent issue of Mayo Clinic Proceedings. I'm really excited about this paper because it combines my interest and passion of data science, outcomes, research, and my interest to understand the interaction of non-cardiovascular disease in patients with heart disease. I'm also delighted to have this opportunity to work closely and publish with my co-authors, Dr. Bobak Zayan from University of California, Los Angeles, Dr. Chip Lovey from Ochsner Medical Center in New Orleans, and senior author, Dr. Greg Fonero from University of California, Los Angeles. In this paper, we aimed to analyze the cardiovascular disease burden in patients who were hospitalized and had a diagnosis of coronavirus from pre-COVID-19 era in United States. The diagnosis of coronavirus was identified using ICD-10 codes, which were introduced for the first time as part of 10th revision of ICD nomenclature. And then we studied the patient demographics, comorbidities, and outcomes of in-hospital mortality and healthcare utilization based upon presence or absence of cardiovascular disease. Overall, we identified 21,300 adult hospitalizations with a diagnosis of coronavirus. And we found that the mean age of the cohort was approximately 64 years, predominantly females with 52%, and predominantly public insurers with approximately 75% of the patients with a payer status of Medicare or Medicaid. We found that the patients with the diagnosis of cardiovascular disease were older, had higher proportion of clinical comorbidities, and also higher Charlson comorbidity index and Alex-Hour comorbidity indices. They were more likely to have a diagnosis of pneumonia, sepsis, shock, acute respiratory failure, and mechanical invasive ventilation. We found that the in-hospital mortality in those with a diagnosis of cardiovascular disease was higher, 5.3% versus 1.5% in those without cardiovascular disease. And in the multivariable logistic regression, even after adjustment for clinical comorbidities, patient demographics, the adjusted odds ratio was 2 with a confidence interval between 1.2 to 3.4. Also, those with the primary diagnosis of cardiovascular disease had similar in-hospital mortality when those to compare who had primary non-cardiovascular disease diagnosis. The mean length of stay was higher for those with cardiovascular disease, approximately 7 days versus 6.1 days in those without cardiovascular disease. The total hospital charges were also significantly higher, 78,377 US dollars versus $66,538 in those without cardiovascular disease. Similarly, the utilization of post-discharge nursing home or similar facilities was also higher in those with cardiovascular disease. To the best of our knowledge, this report, using a national administrative data set from non-pandemic pre-COVID-19 era, is the largest and first description of hospitalizations with a diagnosis of coronavirus in the United States. Our study demonstrates that cardiovascular disease was present in 56% of hospitalizations and were associated with worse outcomes. As you can see in figure 2, we also show that the seasonal variability of viral infections for, for coronavirus was present in our cohort also. We found that the proportion of hospitalizations with the diagnosis of coronavirus increased starting the months of October, reaching the peak between December to January, and subsequently downtrended starting February to March timeline. We also found that the monthly proportion of patients with cardiovascular disease and mortality remained high and did not change significantly with admission months in our study. In our paper, to account for possible confounding from multiple factors that can influence mortality, we rigorously adjusted our findings for age, other demographic factors, and comorbidities. Despite such adjustments, the persistence of significantly increased risk of poorer outcome strengthens the validity of our findings. Although our findings are not unexpected, our report does help to raise awareness about high risk of coronavirus hospitalizations with cardiovascular disease in pre-COVID-19 era. It also emphasizes the need for further research, clinical care tracks, and other strategies to mitigate the adverse outcomes and improve healthcare efficiency. Thanks a lot for your attention, and I hope that you will enjoy reading our paper. Thank you.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.